Ian, thanks so much for jumping on the podcast today. Really appreciate it.
Happy to be here.
Yeah, so I was reading some of your papers that you had published recently and decided to reach out. I thought they were very interesting and a topic that I think is really important to address, especially for people who are interested in bodybuilding, both natural and untested bodybuilding. But for those who perhaps aren't familiar with yourself, it would be great if you could do a quick introduction, who you are, your background, etc.
Yeah, so my name is Ian Steele. I live over in the United States. I'm a psychiatrist, and then I do have a subspecialty within psychiatry. It's called Consult Liason Psychiatry. I think previously, over the last couple of years, it changed from psychosomatic psychiatry to Consult Liaison. So I work with more medically complex patients. But I don't personally have a background in bodybuilding, but my brother, who's a year younger than me, is a bodybuilder. He's in the non-tested realm. Yeah. He has done numerous competitions. I think he was Mr. Iowa, and is also a bodybuilding coach as well. So and when he started, I went to several of his competitions. So, and found it kind of a fascinating world. Other than him, I had never met one, and then going to these competitions, I found it kind of fascinating. Kind of wanted to understand it a little bit more. So that's kind of how I got into it. And then doing psychiatry, we had for training, we had to do an academic project, and I always had this kind of idea, like I wanted to do something on bodybuilding, just if I could. Luckily, Skip Pope, who I trained out in Boston, Massachusetts. Skip Pope is in Boston, Massachusetts. So when I suggested to my research advisor, hey, here's what I want to do, just kind of thought maybe he'll say like, that's not possible. Like, that's not a real thing. He's like, oh yeah, we have Skip Pope over on the other side of town. We'll introduce you, and then you can do your research with him. So that's kind of how I got started in all this.
And in terms of your kind of academic background, kind of what was your kind of studies in, and how did you become where you are today, and what institution were you at?
So I did my undergrad. I got a bachelor's in philosophy, and then I did med school, both undergrad and medical school at Creighton University in Omaha, Nebraska. And I did my psychiatry residency training as well as fellowship out in Boston at Harvard Longwood, which is a combination of several hospitals there. And then I graduated my fellowship in 2019. And then now currently working at the Medical College of Wisconsin in Milwaukee, Wisconsin.
Seems like a long route to get to where you are. I know it's slightly different in the US than it is in the UK or Europe or Australia. Do you have to go and do you have to do medical school then to specialize in psychiatry? Is that how it works?
Medical school for 4 years, and then psychiatry for another 4 years, and then after that, if you want to do a fellowship, there's several fellowships that it's either 1 or 2 years after that. So this is my technical first real job for the past 2 years. Otherwise, I've spent 26 years in schooling technically.
Real, that's a lot. And just when you finish medical school in the US, when you do your 4 years, are you qualified as anything, or do you have to then specialize, even if you want to be I don't know, are they called general practitioners in the US as well?
Yeah. Technically, you're a doctor. Legally, you could practice, but you're not board certified. I don't know if they have that over in Europe, but you have to do usually do a general practitioner. They do a 3-year program, and then you have to take certification boards to get a state license. 99.9% of people do that. Technically, you don't have to, but that's a little dicey, and most people, that's how lawsuits happen. But medical school is like basically you spend 4 years figuring out what you want to do. Do you want to go into surgery? Do you want to go to psychiatry? Do you want to go your endocrinologist? So the 4 years are spent taking a bunch of tests and then figuring out what subspecialty want to go to, like psychiatry, in my for me personally.
So on a day-to-day basis, you currently work as a psychiatrist in a hospital in Boston. Is that correct, or did you say Iowa?
I'm back in Wisconsin, actually.
Okay.
But yeah, I work
Good.
mostly within the hospitals, like the emergency room, ICUs, medical floors, and then I do a little bit of outpatient work in specifically with transplant patients, people who either are going to get or have gotten like heart transplants, lung transplants, livers. And I also volunteer I treat a psychiatric consultant to the great apes at the Milwaukee County Zoo. So gorillas, baboons, an orangutan, also under my care.
Didn't even know there was such a thing. That's interesting. Yeah, that's just out of curiosity. How do you? Is it just observational, or like you can't do any talk therapy, obviously, with them?
A lot of it's observational, and we work along with like the handlers and the vets. So it's, a lot of it's, it's fascinating, but we use a lot. We kind of help them make medication recommendations, like, because they share 98.3% of our DNA. Like, they do get anxiety, depression, or OCD behaviors. So we treat pretty much the same meds, but because veterinarians don't have any training with psychiatric meds, because there's no research, there's no studies, they don't know anything about it, which is reasonable. We help them kind of make medication adjustments, or do we think, is this anxiety / or something else going on, something medical or something else that they need to. But we work with the handlers who do a lot more the behavioral stuff, and when the behavioral stuff doesn't work, then they kind of come to us for medication recommendations.
That's fascinating. But yeah, so the paper that, one of the two papers that you were leading on was called "Is Bodybuilding Pathological?" It would be interesting, I guess, first to maybe explain what does that mean, the word pathological mean, and then kind of what some of the key findings were from that paper, plus the other additional paper that I guess was a follow-up where you actually did a case study. Or sorry, not a case study, a survey.
Yeah. So I think with pathological, we were, it's, at least in the United States, I'm guessing over there too, is this, they hold Mr. Olympia in, I think it's Las Vegas, but like, so it's this huge, event, thousands and thousands of people come all over, but, when you look at them, people assume like there's got to be quote unquote something wrong with them, because why would you want to get that big? What are they doing? That's not quote unquote normal. And when thinking psychologically / psychiatrically, we wonder, is there something pathological? Is there something quote unquote abnormal, or something going on, kind of like OCD, or something that's driving that is not the norm, or it's not okay, if you will. So we were thinking, like, is it just an athlete, or is it something more like, yes, they're that big, but they're that big because they're driven by something that's maladaptive, if you will. So that's what we've titled that paper, just because not that we didn't assume that it's pathological, but we also there's some smattering of research out there of like, do they have depression, anxiety, this, muscle dysmorphia? Basically, Dr. Skip Pope coined the term, but it used to be called reverse anorexia. They think they're never big enough. Is that why they're like that? Is that they driven because they never think they're big enough? Because if there's something wrong, not that bodybuilding is wrong, but if there's something that they're putting themselves in harm's way, they're doing things that are dangerous to be that, should there be think of an intervention to help them be safe, they can continue bodybuilding, but do it in a safe manner. So this is kind of where we kind of thought about it, is like, what psychiatric pathologies are there, if any, We didn't go in assuming there was, which I think was part of it, because at least in the United States, a lot of journals, medical journals, don't like to publish what we call like negative studies, things that say, "Oh, it's fine." That's not
like publication bias, right?
Yeah, it's not sexy. It's not, oh, they're fine. Why would that's not fun journal to read? But I thought it was.
It's like when you try an intervention, there's no results, so let's not publish it.
Yeah, which I thought, I talked to my colleagues, like I kind of want to publish that just because, me knowing knowing my brother and being around a lot of them, like I don't see them as pathological, but I know, I show my friends or people a picture of my brother who is 300 pounds, huge compared to me. They're like, a lot of them, it's not coming. What's wrong with him? Why would you do that? There's nothing wrong with him. That was my kind of going into it. Like, I don't think there is anything wrong, but because it's a rapidly growing sport, a lot of people are doing it more. It'd be important for other, physicians, primary care doctors, other psychiatrists, other people who may interact with them, have this and say, okay, it's not pathological. And if there are some things, or they're more likely to have, depression, anxiety, OCD, and muscle dysmorphia, what can they do about it, or how to look at it? So that was kind of what how we got into the paper and what we wanted to start it.
Yeah. Just the question on that is, I don't know if research has been done because it's not my wheelhouse, but if you're looking at other, say, elite sports, because obviously you're talking about your brother, if he's 300 pounds, he would be the top percentile of bodybuilders. There's many bodybuilders who are 190 pounds. Probably the majority of them are smaller. And even amongst people who use anabolics, it's probably a lot more prevalent than many people think. It's not just the guys who are 300 pounds. It's probably a lot of people, recreational gym goers. But when you're looking at other sports like elite basketball players or sprinters or football players, would there be similar questions? I know that maybe the general public don't look at it that way, but would there be tendencies to think that if someone's so driven to be the top of something, that perhaps there would be crossovers or similarities, and one just doesn't manifest itself physically because bodybuilding is you're building muscle, whereas the others you're trying to be the best, but maybe through another expression of performance?
Yeah, I mean, I think and that was also part of the reason why we kind of, wanted to put it out there, because, if you look at, there are actually a lot of similarities. Other sports use steroids, despite saying they don't. I mean, bodybuilders, there's, the non-natural bodybuilders is kind of like maybe an understood thing, but other than that, like basketball, football, the Olympics, it's kind of a televised thing where, they hold them up, on a pedestal. I mean, and they're looked at as all great, whereas bodybuilders, it looks like it's kind of like an offshoot. It's like, oh, they're weird, that they're not a quote unquote true athlete. They're not, they look at bodybuilders different than they look at an NBA or NFL player, or because it's a not very popular sport, if you will. But there are a lot of similarities. I think, they're coming, at least especially now, coming out more, and especially with this last Olympics. There's like, a lot of the athletes, I've suffered with depression. I suffer, the gymnastics, a lot of eating disorders. A lot of them will overtrain, they'll push themselves past to injuries. And a lot of that is, similarities between bodybuilders is just, and again, all those athletes who, prior to the last, few years, who talks about it? Like, when Michael Phelps came out and was promoting it, before that, it's like, you don't talk about it. So I think there are a lot of similarities that can be drawn from other sports, but, we wanted to point out, like, they are similar to them. They're not dissimilar to, an elite NBA, NFL, baseball player, whatever sport it is.
Mm. And then so what were the kind of the key things that you looked at when you did your research in terms of the questions that you were asking or the hypothesis that you were trying to generate?
We were looking at various different. I mean, it was hard to, because it can be a little bit complex. But we tried to kind of hit the bigger highlights, like, you know, one specifically, it was muscle dysmorphia. You know, this kind of, you know, always feeling like you're not big enough. You know, substance use, steroids, of course, but also other substances, either, you know, illicit, like, you know, cocaine, heroin, but also, you know, medical drugs like, you know, thyroid hormones, insulin, you know, various kind of things that you wouldn't consider drugs. They're substances to, you know, enhance themselves. And then, like, of course, eating disorders, because their eating habits are unique, if you say the least. And then, like, basically other aspects, you know, kind of regular, are they more predisposed to depression, anxiety, OCD, those type of, you know, more common things.
And what did you find with? So you kind of mentioned there, your colleague had kind of coined the term, was it reverse anorexia? I don't know if that's the official term for muscle dysmorphia, but did you find that it was quite common in bodybuilders? I mean, I don't know any bodybuilder who doesn't want to get bigger, because that's kind of like when we kind of compare it to, say, like sprinting. You know, it's there's very few things you measured by, and that's you want to get faster. And bodybuilders kind of like of course, some people want to get better conditioned and leaner and stuff like that, but ultimately always want to be bigger, right? So is that something that's an issue, or is that something that's perhaps just part of the sport or the performance or whatever you want to call it?
Yeah, I think, you know, they're compared to any other sport. Yes, it's more prevalent, but the actual prevalence and actual, you know, how common is it? Because if you think of a pathological disorder, I mean, again, all bodybuilders want to be the biggest. Again, that's part of the sport, but usually when we think of pathological, it goes to the point where it starts impairing their, you know, things outside of the sport. So, like, they can't hold down a job, they can't maintain relationships. It kind of ruins everything else outside of the sport, kind of all consuming. Versus, like, I want to be bigger, they do it, but they can still hold a job, they can still have, you know, if they want a family, if they want, you know, they're able to keep friends, they're able to do things that they want to do. It's not creating such an issue. That's usually how we kind of define something pathological, where it's
Okay.
part of it, but then it pushes it back over where it just kind of destroys everything else. And because it was 2013, it was finally added to the DSM-5, as an actual kind of disorder under the body dysmorphic disorder subtype. Before, there's not a lot of research, so, like, a lot of the, you know, studies use a lot of scales, which you know, they're good and bad. You know, they're helpful because it's a more simplified kind of way to ask questions to see if someone has a diagnosis. Like, they have various scales for depression, various scales for anxiety. They can be helpful for research. The problem is, like, when you can't go into detail if you're asking someone, like, how impairing is it. You know, if you ask someone with kind of chronic depression who, like, never gets better, you know, are they truly depressed, or is it like kind of it's something kind of a characterological issue, not so much a true major depressive episode. So, like, the range goes from, like, I think, like 3% to like 50%, some high. So I think it's there. I think, you know, it's also tough to say, like, how, you know, so how truly prevalent is it? I think it is there. I think 50% is probably a little bit too high. 3%, maybe a little bit lower, but it's definitely there.
So this was like 3 to 50% of the population that you surveyed. Is that correct?
Yeah, well, we
Of
weren't able to, because the survey, we actually took a survey we took data from a survey that was already published. Some a guy out in California, Eric Ep, he sent out this huge survey a few years before and used it. And published something specifically on steroids. But he had a lot of this data just kind of sitting there not being used, and we asked him if we could use that data looking between competitive bodybuilders and non-competitive bodybuilders, and looking at those things. So he didn't look specifically at muscle dysmorphia. We kind of asked questions that may kind of be an approximate answer, which was about the same. About the same number of people who were specifically in the big survey. I think about, was it 20%, 40% of each, the competitive, and then kind of the recreational bodybuilders. 40%, they were kind of preoccupied with their body, kind of are they in small imperfections, and then 20% of those it caused issues. So I mean, again, it was not a full criteria for muscle dysmorphia, but a number of them. So it's probably less. If you try to actually go through each of them by a one-on-one interview, there's probably around maybe 3-5% of them total probably had met criteria. I mean, a lot of them are preoccupied with their appearance, but again, half of a fifth of those people who were preoccupied, it actually caused issues where they wouldn't go out to Netflix. They wouldn't, go out to restaurants. It kind of prevented them from living their life, if you will.
Okay, so these may not necessarily be competitive bodybuilders.
Yeah, I mean, both competitive, and it was about the same in each, which is it was interesting. So we were also thinking of we kind of narrowed it to specifically competitive, just because if you're competing, you're more likely to push yourself, more likely to kind of again, we were thinking maybe be at a higher risk for having some of these disorders, but it kind of showed it did.
And then I guess a question probably always would be, and I do see this particularly with, say, eating disorders or perhaps some issues with kind of self-image, is that are these pre-existing and people get into bodybuilding because they have these, or is it that the bodybuilding itself can actually exasperate these things? So like with social media, and I'm sure you're aware that there's now not just bodybuilding, but you have like the men's physique classes, which is kind of veers more into what normal people would like to look like. It's not huge. It's beach lean. It's typically not like what you're going to actually see on the beach, but what you see on the beach magazines. And then I have read some research that the prevalence of issues, eating disorder, etc., with these kind of with those competitors is typically can be higher than bodybuilding, because often people are driven more so for a specific image rather than stepping on stage bodybuilding because they want to be bodybuilder. They're doing it for maybe external reasons to look a certain way. I think, and because social media have a huge influence on that. It's perceived that you look better, you have a better lifestyle. It's equated kind of similarly. But I think often, and this is just my anecdote, but with bodybuilding, it's like not many people in the general public actually want to look like a bodybuilder, nor step on stage with like a little thong. So it's kind of different than a men's physique competitor who might be 180 pounds, even if they're using anabolics, or 190 pounds, whereas a bodybuilder could be 250 pounds at 5'9". So it's like those people who are perhaps want to do bodybuilding maybe are not so preoccupied with trying to perhaps impress others. I don't know if you have any kind of thoughts on that.
Yeah, I think it's whether there's some pre-bodybuilding image issues. I think the research that is out there, it's a little mixed. So I think yes, there's some that had they got into bodybuilding because they did not like the way they looked. But there's also studies that show no, that I didn't have it. I kind of wanted to look like that. I didn't necessarily not like the way I looked. It was something I had always found fascinating. So I think there's definitely, some of them are there because they hated the way they looked. They had a lot of body image issues, but again, that's, again, why I kind of want to I like this kind of negative study because it did kind of show that it's not necessarily all because they hated the way they look. It's not all about their image. Some of them liked that image and wanted to be that. Not that they necessarily didn't like it. They're current ones that they want to be a bodybuilder. But yes, I think that's not many people want to look like that. So I think that's why a lot of people do look at them and say, "Oh, there's something wrong with them." Who would want to look like that? Who would want to be rail thin? I mean, some people. But again, the bodybuilders tend to, because they're so kind of exaggerated, people wanted to kind of almost want to assume there's something wrong. So I think there's a subset of them that probably have, but I think that's not a 100% thing. But with eating disorders, there is a higher prevalence. With the research they've, the second paper, the one with the survey, again, we were using someone else's questions, a lot of data that we weren't able to kind of get a detailed, specifically around eating disorders. I think, but the first paper, the review kind of the literature out there, show there's a decent amount of them that have had history of what sounds like, an eating disorder. The male bodybuilders, primarily bulimia or kind of an unspecified, eating disorder. I know Skip Pope, he did a survey of competitive male bodybuilders, and I think 3% of them had a history of anorexia, which male anorexia is exceedingly rare. I think it's 1-2% of the population. It's extremely small. So 3% was a huge, for a male anorexic.
So does this mean that does that mean that they previously had it and they're recovered? Because you can't really be a bodybuilder if you're anorexic, right? So would that be seen as a positive thing then? Or would it be seen as an obsessive thing?
I think that's it was tough to say because I didn't have a one-to-one interview to figure it out. But you wonder if, because anorexia is such an intense, obsessive eating disorder, like it is the deadliest psychiatric illness there is. It has the highest mortality rate, but they're extremely obsessive. So you do wonder if they go from rail thin to because they didn't have the size of the bodybuilders, but to a bodybuilding, is it positive? Yes, they're not real thin, but are they doing things to the point where they're probably putting themselves at risk to be a bodybuilder? But a lot of male bodybuilders have a history of what's again, the research is always possible diagnosis of bulimia because you have to actually interview them to give them an actual diagnosis. But there's a higher prevalence in bodybuilders, and then female bodybuilders have a lot higher prevalence, bulimia and anorexia. Do they, often it's in the past, so it's, in a lot of the research didn't say how far in the past, so is it years and years and years ago, where, teenage years, and then they got out of it and then they be bodybuilder, or is it right before bodybuilding? Was it during a period of their bodybuilding, then kind of went one way? In bulimics can be, you can be bulimic and still be huge. It's more about at least the diagnostic criteria now is you don't have to be a certain weight or BMI. It's more of the pattern of behavior. So a lot of it's like, did you have to purge after eating, or you binge eat more than you wanted to, which that's what I think more male bodybuilders have history of bulimia, or what maybe considered bulimic reversal, where they're eating, but like they ate too much for that meal, an excessive amount, then they threw it up. They used various laxatives or something to purge themselves. And there's a lot of emotional distress, like I'm ashamed of myself. This is a bad thing, as opposed to I need to eat this huge amount because if I don't, I'm gonna lose all my muscle mass because I'm burning so much calories just having this much muscle mass. So a lot of it's the kind of psychological in aspect plus the pattern behavior. So there's a decent amount, at least a lifetime prevalence of them having it. It doesn't sound like they had any actively, but could the bodybuilding then help them regulate it and have kind of a more structured, as opposed to binging and purging and trying to regulate themselves, where if you're in a competition, you have such a set regimen of when to eat, when not to eat, what to do. Did that help them? Again, it's not a lot of research out there on bodybuilders in general, so it's tough to say, but that could have been part of it.
I wanted to touch a little bit on the use of steroids in bodybuilding. Did you find that there was certain differences between those who did and did not use them? I know you mentioned that perhaps, and I read that recreational drug use is slightly higher. That kind of makes sense. People who, I know in the US, it's I think it's illegal. And some of the other drugs, right, that I know just from friends and things like that, some of the drugs that they would use are not even for humans. So someone, who's taking, equipoise or something that's for horses, they're going to be more likely to take risks with recreational Class A drugs or whatever, because they're just a riskier person, right? Was there specific findings between people who did and did not use them in terms of the type of person they were, or their actions or behaviors?
Not exceedingly. I think the only difference that we saw really was that the non-users may have used a little bit more recreational drugs. In the large study with the survey, the competitive users and the non-competitive users, the only difference there is that the non-competitive were more likely to have used, marijuana. But other than that, there's not as much, a huge difference. They looked at maybe the people, the competitors using it, maybe have used a little bit longer. They started earlier, at an earlier age, versus the recreational bodybuilders maybe started a little bit later. The statistical significance really didn't show much difference. I mean, there was kind of a trend, maybe a little bit longer cycles, maybe a little bit more in the competitive versus recreational, but otherwise not a huge difference. But I think, again, the users and the other papers, like the users were more likely to use other substances in addition to steroids, such as thyroid hormones, HGH, insulin, other fat burning substances. So they're more likely to use those type of things, which we don't. I wouldn't consider illegal substances. Because they're often more focused on health. These would be kind of appearance enhancing performing drugs. So, fat burning drugs, things to help counteract the steroid issues like gynecomastia. So they're more likely to use those in addition to steroids than the non-users, which, again, those do put yourself at risk for other side effects. So it's not cocaine or heroin, but, using those things are not insignificant, if you think of health-wise.
Yeah, I think people often confuse bodybuilding with health, or training for health, especially when you're getting huge. Like any sport, if you're going to the top, it's probably not going to be the best thing you can do for your health. But did you find with any specific say, users that were obviously, most likely going to be larger? And did they have a higher incidence rate of muscle dysmorphia or anything like that, or did you find that it was pretty consistent? There was no indicators of why someone would use versus not use anabolics or other kind of associated like thyroid drugs or etc. insulin.
Yeah, I think the research was a little, has been again a little mixed, because often the muscle dysmorphia diagnosis, they're using different kind of assessments, different kind of surveys to kind of correlate a diagnosis. It seems that there's probably a more likelihood that if you have muscle dysmorphia, you're more likely to use steroids, which kind of makes sense because muscle dysmorphia, part of the criteria is like you put yourself in risky situations, you do unsafe behaviors, such as using substances to make yourself bigger, work past injuries. So yeah, there is the percentage, and how big they are. Are the 300 pounds more likely to do it? Have muscle dysmorphia and steroids versus, again, the smaller ones. That hasn't really. There's not a lot of research around that, mostly because it's a little hard to. I think one of the paper, so the survey, well, we kind of pointed out our limitations. Like we weren't able to kind of really go through and nitpick which category. Was the Arnold Classics, were they the 212s, were they the physiques? We weren't able to kind of stratify those into the seal in the kind of really detailed aspects. Is there a category that's more likely? And I haven't seen a lot of research out there that has really been able to do that, just because they're either they didn't think about it, or they it wasn't really feasible numbers wise.
Yeah, I know it's not really scientific though to be asking this, but as a practitioner, what would your kind of thoughts would be on that? Like, would you think that there's a higher rate, or is there any kind of, or is there particular reasons why people would turn to that, or do you think it's just more some people are more competitive?
What the research I've found out there is it's not. There's a couple papers out there that they looked at why did you choose to use steroids? Were you influenced by others? Were you influenced, peer pressure? A lot of it's actually just got their own desire to get to that level. Are they, the competitors do tend to have more steroid use. That's been said, but like the reasons why it's kind of all over the place. So it's a kind of an individual base. Like, I really wanted to be that big, that I needed to use it to be at that elite level. Again, we see that in other sports too. Baseball, definitely big. Yeah. But it's not. It's not like a primarily just one. Like, I was peer pressured into it, or
yeah. So it's like kind of like other sports where they would do it. You probably see it's more common towards the top end of the sport versus the amateurs. And it's not necessarily bodybuilding. It's not a pathological or reason where they just want to get bigger. It's perhaps they just want to get to the top of the sport, like other sports. Yeah,
because if you look at what bodybuilding used to be, like Eugene Spandau, like the original guy, his physique versus now, Phil Heath, Green, like those guys, like you can't. It's impossible not to use steroids to get to that, and if that's what is the gold standard,
yeah,
you kind of have to. So if you have a desire, do we blame bodybuilding to use steroids? I would kind of hesitate to say like bodybuilding itself. Again, is it itself pathological? Because again, there's natural bodybuilding. There's some people who really just are muscular just because of their genetics, and they don't really need use steroids, and there's some people who do need, even to get to 180 pounds. So I think I think in some of the papers too, I think it's some of the society-wise is, if you look at the GI Joe from like the 1950s to like now, like the proportions are just kind of ridiculous. So even the male action models would look like a pro bodybuilder. So all these kids, all these kids are looking at what a masculine male should look like, and it's extremely disproportionate to what it is in real life and what it used to be like 40 years ago.
I'm curious, would society influence that, or would the way that people are looking influence the way that companies are marketing? That would be kind of curious. I know it's probably a difficult question to answer, but yeah, the same would be true with kind of women as well, right? I know that like even hundreds of years ago, I think it was, but it was admired to be overweight or bigger because it was a sign of wealth, right? And if you were pale as well because you didn't work outside. Now pale is probably the opposite.
Yeah, and I think it's probably a little bit of both. Again, I know there's research out there that kind of has probably looked at this, but yeah, it's probably kind of what did someone like this did athletes start to become bigger, and then people wanted to be like athletes, so the society they made toys bigger, and kind of now it's so ingrained that it's hard to say, because I was just thinking of the Rocky movies, like I mean the original ones, like they're Sylvester Stallone, them are big, but like then you look at the later ones, like it grew exponentially. So like, was it society? Was it was it just he wanted to? What kind of pushed him that way? Did they I don't know, like it's I'm sure it's a combination of both of the marketing campaigns wanting to promote products, so if people want to look like that, they're willing to do that, but also people wanting that, seeing before even the advertisements, and that aspect kind of caught up.
Yeah, it's very interesting. So then in general, then compared to your findings compared to say just the general population of people, did you find that there was anything significantly different between bodybuilders and then just average general population, and anything kind of to be aware of, or at a personal level, or if people are listening that are practitioners and that work with people from a kind of mental health side of things?
Yeah, I think again the research has been a little mixed, mostly because it was hard to make really good, sound, standardized research in this field, because it's one that costs money, and two, it is a little bit nebulous, especially in all psychiatry research. So unless you're looking specific at a drug, population based, often, I think there is a little bit. Then again, comparing to the general population, bodybuilders, especially competitive ones and higher up, like there are higher levels of depression than maybe the general population. Eating disorders, of course. Again, for practitioners, you want to think of like, yes, their bodybuilders have an interesting eating regimen. Especially you don't eat when you're hungry. You eat based on your schedule. Is that you want to really think about, is this disordered eating, or is this just part of the sport? Is it causing them distress? Is it causing issues within their personal lives, or is it no, it doesn't bother them, everything's fine, it's just they eat differently than you? But I think they do have a little higher rates of depression and anxiety. With the steroid use, I think my personal opinion is, I want practitioners to be a little bit more, open-minded, and because with my brother, and always wanting to make sure people are healthy, like make sure they do have a primary care doctor, and like be honest with them, like to say, are you using various substances? Because the last thing, if you're using these, if you're not getting blood tests, you don't know what's going on with your blood, your heart or kidneys. And, I want practitioners to know, like, if they are, don't just kind of focus on that, harp on that, because it kind of shuts people down. Like, if that's all they're going to talk about, then I'm not going to come see a doctor, because they're just going to say, you're using steroids, or you're doing this, or I think the sport's wrong, you shouldn't be doing that. They're not going to go to the doctor, but like, make sure they're healthy, and if, that they're informed about the risks, and, routinely checking them, various, blood levels, organ systems, just to make sure, because if they're using they're putting risk of side effects that, the bodybuilder, the athlete should know what's going on with their body, but not to push them away. And then do focus on, like, checking if they're doing okay in their personal life, because if the competitive ones are getting up there, they're pro, what's their personal life like? Are you able to go out in public? Are you able to keep, assuming that they have another job, like, are you able to keep jobs? So I know, my brother was saying, just kind of knowing people and in the bodybuilding field, like, a lot of them, either turn down promotions or hard time keeping a job because of their just kind of obsession about working out, and, the regiment that they feel like they have to keep, but they can't keep a job, which, I think it's a balance with bodybuilding, and, because it is a much different style of, a sport than other ones. But, like, is it impairing them in some way? Because if it's not, then they're fine. They're friends. They're able to do things, or, they're okay. Then they're okay. But, there's physical health that you want to watch out for, and also the mental health. Because if they're struggling with depression, research has shown, like, people with muscle dysmorphia, they are a higher predilection to have other OCD, like trichotillomania, other kind of obsessions, which is not uncommon in things like, people with eating disorders have a high rate of depression, anxiety, muscle dysmorphia. Again, having one mental health diagnosis, puts you at risk for having another. I don't want to say it's a good or bad thing, is just kind of how it is. Again, it's not just depression. Depression, anxiety are intertwined. Sometimes it's hard to tease them apart, but, like, anorexia, a lot of them, I think they have a higher incidence of OCD because of just how they are, kind of the obsessiveness. So it's, you want to kind of watch out for, those things, because if they're there, you want to treat them, because it's not so much quit bodybuilding. You'll be bodybuilding and depressed or have these issues, or quit and you'll be fine. And that you can be a bodybuilder and not be depressed, or be a bodybuilder and not have these kind of issues. So, my hope is to, like, have bodybuilders be comfortable going to a practitioner, whether it's a psychiatrist or a primary care doctor or whoever, to get help, because it's not, it's not a weakness. It's, you want to think of it as, I'm taking control. If I want to keep doing this, I need to get this aspect of me, treated, so I can keep doing it, as opposed to, oh, I have depression or anxiety or, bulimia. I'm a failure. I'm weak. It's not, I'll just push in the back of my mind, it'll be fine. That's usually not kind of how it works. And usually, if untreated, mental health issues usually become all consuming, and, you can't continue being a bodybuilder if those aren't treated. So I always, like, try to think of it as, in order to keep doing what you want to do, you got to get this aspect treated. Again, I want practitioners to think about that too. Like, don't think of it as, like, they need to quit bodybuilding and they'll be happy, they might actually just like bodybuilding, but, they're doing something that's causing an issue, that's causing them to have depression. Treat the depression, because quitting bodybuilding is not always just the answer, because if that's what they love to do, that's not going to help, depression or their anxiety.
Yeah, definitely some food for thought, and thank you for the insights. Is It's been great having you on, Ian. Is there anywhere that people can go to find out more about yourself or your work, or is there anything planned down the line?
Down the line, I mean, I have goals of opening like a sports a clinic within a sports psychiatry clinic. I know we have some professional teams here, so I think the College of Wisconsin is associated with like the Milwaukee Bucks and the professional teams here, so working with them. That was kind of a goal of mine.
They had a good season. They had a good season this year.
Finally. But I think, there's stuff about, me that, if you just type in my name, in Medical College of Wisconsin. But I think and for practitioners, the one of the books we put out is I'll just show it. It's the ISSP Manual of Sports Psychiatry, and it does go throughout all the individual sports. Like it goes, weightlifting, golf, rowing, soccer. I mean, it goes through like pretty much everything for at least a general sense of what issues are, treatment recommendations, how to think about treating, the eating disorders, depression, these type of athletes, weightlifting, like what things to think about if they're using certain types of substances. I think it's people found it helpful to have, because it's not extremely detailed, but it's enough where they know what to look for, and if they want to look a little bit further, they kind of have an idea what to look for.
Great. I'll put the link to that, and I'll put the link to the papers that we chatted about as well in the show notes. But once again, thank you for coming on, Ian, and have a great evening.
Yeah, thanks for having me.